Hi, my name is Dr. Colin Pritchard. I am a molecular pathologist based at the University of Washington Department of Laboratory Medicine in Seattle. And I'm pleased to go over a talk that I presented October 4th, 2019 at the Philadelphia Consensus Conference related to molecular insights into the germline for prostate cancer initiation, progression, and aggressiveness. So there's this emerging model for advanced prostate cancer where germline tissue, that is tissues that have inherited mutations, tumor, and liquid biopsy, that is also known as cell-free DNA or plasma cell-free DNA, are routinely evaluated for prostate cancer patients. Therapy is guided by both the germline or inherited genetic findings and the somatic or acquired findings in the tumors. So this is really a paradigm shift. And then, importantly, genetic counseling is based on both the germline and somatic findings. So that's interesting too. So this is really brand new, just in the last few years that this model for advanced prostate cancer patients is being adopted. Poses a lot of new opportunities for prostate cancer patients, as well as a lot of challenges in understanding what the right approach is. So when we're talking about the key mutations we're looking for on the germline side and on the somatic side as well, DNA damage repair pathways are really central. And for those of you watching who are really gurus in DNA damage repair, you know that there are, at least 6, maybe up to a dozen different pathways in DNA damage repair. But there are really 2 pathways that we focus on in terms of really what I like to call the heavy hitters, where we know a lot right now about what they mean in terms of germline mutations and somatic. And those are homologous recombination DNA repair, of which the best known examples are BRCA1 and BRCA2, and mismatch repair. I'm giving an example of a key gene in prostate cancer, MSH2. And so the germline risks associated with homologous recombination DNA repair, prostate cancer, breast, ovary. There's also treatment implications with PARP inhibitors and platinum-based chemotherapy, and then mismatch repair. Again, prostate cancer, of course, colon cancer, endometrial. This is Lynch Syndrome. And then checkpoint blockade immunotherapies are associated with defective mismatch repair, which results in microsatellite instability. So if we look at DNA damage repair mutation prevalence, which is abbreviated as DDR here, in metastatic prostate cancer, this is just approximate. It's based on a number of studies, including consortium work that I was involved with and also many other studies. I think the good rule of thumb is that for homologous recombination DNA repair defects, if you take the sort of pie overall in prostate cancer, about half the time it's going to be somatic only, or sometimes called double somatic, and half the time it's going to be germline as an inherited first hit. That's somatic. So if you look at BRCA2, about 5% of all metastatic prostate cancer patients will have an inherited BRCA2, and about 5% will have double somatic. So overall, 10%. BRCA1 is only about 1% germline, again, 1% somatic, 2% overall. PALB2 prevalence estimates are still emerging, probably about 0.5%. ATM, about 2% germline, about 2-3% double somatic. And then, then if you look at mismatch repair, so the Lynch genes, it's not like that. So while Lynch is an important part of predisposition of prostate cancer, it's actually far more common to have somatic mutations in mismatch repair in prostate than germline. So it's about 4-1. So if you look at MSH2 and MSH6 as 2 of the key genes, Lynch genes in prostate cancer, only about 1% of advanced prostate cancer patients will have germline mutations in these genes, but about 4 to 5%, depending on what study you look at, will have somatic. And so you can look for clues both in the clinical and family history, but also in histology for enrichment of these genes. So for homologous recombination DNA repair, which would include BRCA2, BRCA1, PALB2, ATM. Family history of breast and ovarian cancer is an important thing to look for to enrich. I mean, if the patient's positive for that, of course, going to have more likely to see that. But also histology, so ductal and intraductal, which are different types of histology, but are both associated with increased prevalence of these germline mutations, are things that to look out for. Intraductal histology in particular has been shown in a couple studies to be associated with BRCA2, increased rates of BRCA2 mutations. For MSH2, 6, family history of Lynch-associated cancers, colon and endometrial, as well as ductal histology, Gleason pattern 5, work from Hopkins group, Tamara Lotan, that we were fortunate to collaborate with, has shown that nicely, that can be maybe up to 8 to 10% of tumors that are primary Gleason pattern 5, that would be the highest grade group in the new system, have mismatch repair. But again, most of that is double somatic and not germline. Okay, so what are some of the features of the DNA damage repair genes commonly tested for? So again, this is just a rough estimates. I mean, I think there's still data emerging. This is not intended to be sort of the final word, but it's sometimes nice to just have kind of a thumbnail sketch of the general gist. So if we look at some of the key genes in the homologous recombination DNA repair pathway, we have to sort of organize these according to prostate cancer risk. So BRCA2, unequivocally a high risk prostate cancer gene, and the list goes down from there. Now, I have listed yes for PALB2, and that might be somewhat controversial. I think a lot of people would reasonably argue that the data is still emerging for PALB2. So we could debate that. There's, if you go down to the bottom of that list of homologous recombination DNA repair genes, genes like FANK-A, I'd kind of put at the bottom. So these are not all the same. And I think that's the bottom line, is that we can't sort of lump these all together. There's different levels of data, some of which is just emerging. So I've given, again, just sort of a rough estimate of responsiveness to PARP platinum inhibitors on the sort of far right of the table. And then also for anti-PD-1, the checkpoint blockade immunotherapy. So again, homologous recombination DNA repair defects in general predict responsiveness to PARP and platinum classes of therapy, and mismatch repair to checkpoint blockade immunotherapy. Anyway, this is a busy slide, and hopefully we've lingered on it long enough for those of you who are interested can kind of look at the key at the bottom and all of these acronyms and so on and so forth. So if we focus on mismatch repair and inherited mismatch repair, that causes Lynch syndrome, of which prostate cancer is part of the spectrum. But what's interesting, and I think is not widely appreciated at this point, hasn't really been emphasized in the literature, is that the specific gene matters for Lynch syndrome. So this is well known in colon and endometrial cancer, other Lynch spectrum cancers, that, for example, if you have a PMS2 germline mutation, you're going to have, that's going to be less penetrant. It's going to be less likely to cause those cancers than, say, MLH1. But what's interesting is there was a paper that came out of a European group, a large a study that looked back at cumulative prostate cancer incidence by gene. And this study looked at all Lynch cancer incidences. And what seemed is sort of striking. So what we're looking at is sort of age range, and then the cumulative incidence of prostate cancer according to the Lynch genes. So when we go up to 75, we can see there's this really striking pattern where MSH2 really seems to be the heavy hitter for prostate cancer. Lynch, of course, MLH1 is important, MSH6 is important, PMS2 wasn't statistically significant in this large series. So it really does matter what gene we're talking about, and I think MSH2 in particular looks to be the most important gene of the Lynch genes that we know about for prostate cancer. And that's sort of in contrast to colon cancer. So there's some interesting biology here that we need to sort of sort out. I mean, if we look at colon cancer, MSH2 and MLH1 are fairly equal, but not true for prostate. All right, so there's some other clues from prostate tumors that tell us that the specific gene matters in terms of Lynch genes and prostate cancer risk. So there's a study that came out about 5 years ago now from the Lynch Syndrome registry that was interesting, that looked at prostate tumors and tumor features in Lynch families where there was prostate cancer. And so if we look in the MSH2 Lynch, 83% of them had evidence of defective mismatch repair and tumor, so evidence that the MSH2 actually caused the prostate cancer. Whereas if you look at MLH1 and MSH6 Lynch, while there were only 9 cases, only 3 out of those 9, a third of them, had evidence of defective mismatch repair in prostate cancer. So I think it's going to be the case that all of the Lynch genes are associated with prostate cancer risk, but to pretty substantially different degrees. So it looks like MSH2 is probably the most penetrant, the most important, well as MLH1, MSH6, and PMS2 are going to be less penetrant. And if you look at Gleason grades, again, the same effect was borne out. So if we switch gears excuse me, to somatic homologous recombination DNA repair testing, I just wanted to highlight a few issues from a molecular pathologist standpoint that are increasingly coming up. So confirming that there is biallelic inactivation is increasingly something that people are asking about. So what do we mean by that? So if we're talking about someone who has is a germline carrier, some of the time the tumor will be caused by that germline mutation, presumably a high percentage of the time, depending on the gene. But some of the time it's going to be true unrelated. So how do we figure that out? And so if you look for second allele inactivation evidence, these are tumor suppressors, so you need to knock out both copies to have the effect, and that's what we mean. So we can confirm that by at the DNA level by just looking for a quote second hit, or looking for what's referred to as loss of heterozygosity, meaning like the other normal copy was kicked out of the tumor. So that's one way of looking. We can also look for the tumor signature that indicates that the pathway has been knocked out. So looking for homologous recombination signature analysis. This is now, there are some commercial tests available for this now. This technology is getting better and better. It's still relatively new. It still works, so maybe not perfectly, but it's getting there. Sort of the analogy would be microsatellite stability for mismatch repair. This is like that, but for homologous recombination DNA repair. And you can also look for immunohistochemistry to look for the protein actually being gone. So there's, for example, there isn't really a good immunohistochemistry assay for BRCA1 or BRCA2, unfortunately, for a variety of technical reasons. But there is an emerging immunohistochemistry assay for ATM, so that could be useful to confirm that the protein's actually gone. And so that's what we mean by confirming biallelic. So the other issue, I think, right now with somatic testing particularly is variant interpretation. So one thing to be aware of is, if you're ordering a somatic only test, by somatic, that's what I mean by is tumor. So if you're ordering a tumor only test, but to a commercial lab, and you're trying to infer the germline status, just be aware that, yes, that tumor only test tells you about the germline, just like it tells you about the tumor, but a lot of these tests really aren't designed to do this. And there's, particularly on the variant interpretation side, some of the commercial labs that are focusing on the tumor side really are still struggling in this area. So it's really not a replacement. If you want to do a germline test, if you want to know about inherited mutations in these genes, you really need to do a germline test, at least in 2019. I think we're getting there, where these fields are kind of converging, and we're going to get to sort of more paired tumor germline tests at a high level that are available. But for the time being, just be aware, it's really a tumor-only test does not suffice. So biallelic inactivation matters. This is data from a paper out of the Memorial Sloan Kettering group recently showing interesting data showing sort of how often, when you have a germline BRCA1 or BRCA2 mutation, how often does that mutation result in biallelic activation of the tumor? And therefore, and the surrogate of that, or the correlate of that, is basically what's the penetrance of that mutation for that tumor type. And so, not surprisingly, the tumors, the cancer types that are already known to be associated with BRCA1 and BRCA2 germline predisposition have a relatively high rate of loss of heterozygosity, that is biallelic activation of the tumor. So breast, ovarian, pancreatic, and prostate, which is highlighted here. Whereas cancer types that are not really well known to be associated with these genes did not have really any meaningful increase in loss of heterozygosity of tumor when you looked at pathogenic variants versus benign. So that suggests that there may be not any cancer predisposition in those other tumor types. But again, this is interesting data, and it shows that biallelic activation probably matters. So if you're looking for, in a non-prostate cancer case, it may be not safe to assume that mutation causes cancer. But even in prostate, it's still going to be some of the time that the cancer was caused by something unrelated to the germline mutation. It's just a question of what percentage of the time is that. In this study, they also they looked at a number of things. They looked at this homologous recombination signature or score, bottom line of this, what I'm showing here is that being biallelic was really the key to having homologous recombination DNA repair score be elevated, which again makes sense because you need to have both copies of the gene gone for a tumor suppressor in order to have the effect. Okay, so I highlighted the variant interpretation, and I guess I want to just emphasize this here. So variant interpretation really matters. I mean, we're seeing, I mean, there's no way to really sugarcoat this. There just really are some serious errors that are being made in terms of variant interpretation, right now, and they're being returned back to patients. So we want to be, if you're a clinician ordering these kinds of tests, again, particularly tumor-only tests where you're then inferring germline status, really beware. You need to be thinking, do I trust that this interpretation is correct? This is the practice of medicine, and it's difficult to do this algorithmically at this point. So here's an example from a study that we have in press right now. It's just one example of this. So if you look at missense variants in BRCA1, so missense variants are the variants that are protein coding, so not necessarily like a stop or frame shift that's truncating, which are usually people consider those obviously pathogenic unless they're very late. But if you look at the tricky ones to classify, these ones that just change the protein coding sequence, well, it turns out that almost all of the missense variants that are important, the pathogenic and likely pathogenic ones, cluster in the two domains at either end of the gene, at the ring domain and the BRCT domain. And sort of strikingly, there's a huge chunk of the gene, more than half the gene, of which there are no known pathogenic or likely pathogenic missense variants. And yet, when you look in ClinVar or other public databases that are used for variant interpretation, there's approaching 2,000 so-called variants of uncertain significance that are in these regions, which we are calling cold spots. And so I think it just highlights that I think we have a long way to go. I mean, do we really want to be reporting back all these variants in regions where it's so unlikely that there's a pathogenic consequence? So I think we have a ways to go with variant interpretation. Somatic mismatch repair, DNA damage repair testing issues. So there's the accuracy of microsatellite instability, which is abbreviated as MSI here, accuracy of immunohistochemistry. It's technically challenging to detect underlying mutations. So these are just a few of the issues to think about. The good news is that with mismatch repair DNA repair testing, MSI is a fairly good test if done properly. But there are definitely some issues for prostate cancer that I'm going to highlight, and I want to make sure that it's understood that MSI applied to prostate cancer is different than MSI applied to colon cancer, which is where it's traditionally been used for the last 20 or 30 years. And so this is a study that was led by Steve Salponte's group at our institution that we were lucky to be a part of, where what Steve's group did is use some software to look at the Cancer Genome Atlas data sets and look at global microsatellite instability, and sort of was able to group it in terms of different flavors of microsatellite instability that were sort of characteristic of certain cancer types. And so what this is highlighting is that the MSI patterns in prostate cancer are actually not the same as MSI patterns in colorectal cancer, and they're not the same as MSI patterns in endometrial cancer. So what this practically means is that when you use an MSI test that's been primarily designed and validated to detect MSI in colon cancer, which is most of our MSI tests, that does not perform as well in prostate cancer. Now, the good news is that companies are sort of, people have caught on to this. Newer generation MSI tests are coming out that I think are going to sort of rectify this issue. But it's still worth, I think, mentioning right now that when you do a standard MSI test for prostate cancer using traditional technology, it may not be as sensitive. And this is a paper we published on this topic about a year ago now, showing the standard MSI test that was validated for colon cancer on the left, and then a next generation sequence expanded test on the right. And bottom line is that there were, it was only about 70% sensitive using the standard test, and it was over 90% sensitive using the expanded next generation sequencing test. So 70% sensitive is not, it's not nothing. The good news is that the specificity is pretty good, even with the older technology, in that there weren't false positives, so that's good. But you're going to be missing cases if you're using just a garden variety MSI test and applying it to detecting MSI in prostate cancer. So somatic testing as a germline screen, I think I've highlighted that already a couple times in this talk. It really is imperfect at best. It's, you know, even if you have a lab that really specializes in both germline and tumor, it's still, you can only go so far when you're doing tumor-only testing. And again, I want to emphasize that commercial somatic tests are really not designed for this. I get consulted on almost a daily basis in trying to reinterpret tumor-only data in terms of, is there likely to be a germline mutation test? It just comes up constantly. So that's why I really want to emphasize they're not designed for that. My go-to advice is, if you're interested in germline, do a germline test. You're obviously concerned about this for your patient, so do the test. You haven't done the test. Variant allele fraction, all that said, variant allele fraction, which is abbreviated VAF here, can be useful, but there are many ways to go wrong. So what we mean by that is the fraction that you see a mutation. So if you have like a BRCA2 mutation at like 80% fraction, and other mutations you see in the tumor are much lower, well, that can be some clue that, well, maybe that was of germline origin. So it can be useful, but there are a lot of ways to get it wrong. And it does require expert consultation if you're going to go down this road of trying to sort of infer or determine what the likelihood is of a germline mutation from tumor-only data. So in summary, germline and tumor next-generation sequencing testing of DNA repair genes is increasingly recommended to guide advanced prostate cancer treatment and risk assessment. I've highlighted some of the things from a molecular pathologist perspective, including the sample, the methods, how the interpretation method matters. And hopefully I've given you some sense for what the increasing molecular pathologist roles are, both assisting with methods and interpretation. And anyway, thank you very much for your time. And I'd like to thank my colleagues at the Genetics and Solid Tumors Lab at the University of Washington, and appreciate the opportunity to have this talk recorded for posterity. Thank you so much.